Okay, let's get started. So hello and welcome to this week's NDARC webinar. My name is Sarah Farnback and I am a researcher here at NDARC. Today, it is my great pleasure to be introducing you to today's webinar. Today, we're hearing from Anke van der Stern and Chris Goff, who are good friends of NDARC, who are joining us today to present a project that they've worked on over the last few years, where they've worked on collaborative development of experience measures. Now, just to introduce Anke, for those who don't know her, she's been working for over 25 years in public health research using mixed methods, mostly in drug and alcohol-based research and workforce capacity building. Anke is also currently completing her professional doctorate in applied public health here at UNSW as well. Now, Chris is the Executive Director of the Canberra Alliance for Harm Minimisation and Advocacy, or CARMA, and also the President of the Australian Illicit and Injecting Drug Users League. So that's AVIL for those who don't know. He identifies as a person who uses drugs and also has expertise centering around peer and consumer-driven programming, including peer leadership, peer treatment support, and community development. After the presentation today, they will be joined by James Poole, who has extensive history in the drug and alcohol sector, working from community neighbourhood programs to detoxes, residential services, community help organisations, just to name a few. Now, James was actually involved in the project that they'll be presenting on today and will bring his own unique advice and insights into the project. He now works at CARMA as a full-time peer treatment support worker. So after the presentation today, we will, as always, be having questions. So if you have any questions that you'd like to raise with the panelists or with the presenters, please use the Q&A function and we'll try to get through them after the talk. Please try and frame them as questions so that we can get through them as quickly as we can. Before we begin, I just want to take a moment to stop and to acknowledge that we are meeting on traditional lands today. I'm joining you today from the Ngunnawal and Ngambri lands, and I wish to welcome in particular any First Nations people joining us today. I think that covers off my job as chair, so I'm going to get out of your way and ask Anke and Chris to please turn on your camera and mic. Hello. Oh, and hi, James in the background. So today we have the unusual honour of having all of our presenters in the one screen, so that's a wonderful welcome, everybody. I'm going to get out of the way and hand over to you to do your talk.
Fantastic. Thank you so much, Sarah. Thanks for inviting us, and we're delighted to be here to present on this project. This is the Service Users Survey of Outcome, Satisfaction and Experience that we're going to be presenting about, or the SUSOSE, and we're going to be talking about the collaborative development of the survey, including an experience measure that's embedded within it. Before continuing, I'd just like to also acknowledge the traditional custodians of the lands that we're meeting on. We're on Ngunnawal country as well, and also acknowledge the Ngambri people from around Lake George area and recognise their ongoing contributions to the life of the ACT and region. So we also have some other acknowledgements for people who've been involved in this project. We've had people involved in focus group discussions as well as participants in the survey, and I'll be describing this in a moment. We have a project advisory group I'll also be talking about, and a number of other stakeholders, drug and alcohol services, and also the ACT Health Directorate, which provides funding to this project. As Sarah mentioned, I'm doing this project as part of professional doctorate. I'm very lucky to be able to meld my professional work at ATOD with doing doctorate work on this particular project, and I receive support from an Australian government research training program scholarship. So we're going to be kind of tag teaming, Chris and I, and we've split this into two parts. I'm first of all going to give a little bit of background about the SUSOSE, how we developed it and why we developed it, just in a more general sense, and then I'll be handing over to Chris and he'll be providing some reflections on the value of involving people with lived experience of drug and alcohol use and service access in the research process that we undertook. So just a little bit of background for anyone who's not familiar with the ACT and in particular the drug and alcohol sector. Canberra, as the main centre in the ACT, is a regional centre, and although the ACT has a population of 480,000, we actually service the entire southeastern corner of New South Wales. So more people than just those 480,000 use our services. And the NMD, according to the NMDS, we had 3,600 service users per annum use our drug and alcohol services. We are a relatively small sector of just 11 drug and alcohol services. One of those is the government service and the others are all non-government services. But across all of those services, we offer all treatment types across all different types of treatment and harm reduction interventions. So I work for ATOD. For anyone who doesn't know, that's the peak organisation, and we represent the drug and alcohol services, so those 11 organisations, and we do policy, advocacy, research and workforce development activities. Chris will talk a little bit more about CARMA in a moment, but just as a general sort of overview, CARMA is a peer support organisation that provides services and programs that support people who use drugs and drug treatment services. And just for anyone who doesn't know, we're very lucky to be living in a jurisdiction that has relatively progressive drug law reform. We have partial legalisation of cannabis, fixed site drug checking, and also decriminalisation of personal possession of drugs. So that's just a bit of the background of where we're working. So as I said, we're talking about the ACT ATOD Service Users Survey of Outcomes, Satisfaction and Experience, which is the SUSOSE. This has been going since 2009 and has been done approximately 3 yearly with people accessing drug and alcohol programs in the ACT across all intervention types. So everything from residential services to withdrawal services and all types of harm reduction services as well. Counselling services, everything, the whole gamut. So we most recently did the survey in 2023, and that's the 5th time that we've done the survey. It's a funded activity of ATODA's, and as I said earlier, we're funded by the ACT Health Directorate to do the survey. It's a requirement of the contracts of drug and alcohol services in the ACT that they participate in it, and it's part of the quality indicators. We're really lucky to be able to do this survey and to have the support of the government to do it. It's a really unique survey. As far as we know, there's no such sector-wide survey done anywhere else in Australia, and it's a really key source of information that we don't have from other data sets. So what's in the survey? We have questions. It's quite a large survey. It takes quite a long time to do. It's about 20 to 30 minutes. And we have demographic questions in there and questions about people's personal circumstances, questions about service access, about self-reported outcomes. And then we have a satisfaction measure in there, which is the CSQ-8, which is the client satisfaction questionnaire, for those of you who are familiar with it. And then we also have a set of experience questions, and I'll talk about that in a moment. It's an experience measure that we've specifically developed for this survey. So why did we design a new survey? So for 2003, as I said, we've been doing this 3 yearly, but specifically for the 2003 survey, we decided that we wanted to redesign it. And we had a look at the survey and realised that really it was meeting the needs of us as a peak body and service providers and the government, but was it really asking the right questions? So we wanted to look at the survey and to look at and to reassess what kinds of questions we were asking. And when we looked at the literature, and there's a QR code here for a scoping review that we did, which looked at the involvement of people who use drug and alcohol services in the development of patient-reported measures of experience, We couldn't find something that was really fit for purpose for our context because there are very few specific drug and alcohol experience measures. Most of them are adapted from other contexts, particularly mental health, and many of them are related to high intensity intervention types. So, for instance, residential services rather than harm reduction services. And we couldn't find anything that was really applicable to an entire sector context and that we could apply in many different settings at the same time. As I said, most of the measures we could find had been developed by researchers and policymakers of service providers, not with the involvement of service users themselves, who would determine the different items that were and questions that were in the measure. And we also couldn't find many of them weren't properly validated either, and hadn't looked at the underlying factor structures, for instance, of the survey. So we decided to do a process of involving service users and peers in a process of developing the actual questionnaire. So later on, I'll present a little bit of data, but I'm not focusing on that today. But if you are interested in seeing the data, this is a report that we wrote and a set of 5 pamphlets, plain language pamphlets, to report back the findings. This is a QR code that leads you to our publications page, and on that you can access that, and you can also access the survey if you're interested in seeing that. So I'm going to focus just on describing the process of collaborative participatory design that we undertook. And I'm going to focus mostly on 3 areas where we formed a project advisory group to guide the project. And we undertook focus group discussions that helped us to identify the themes of experience that we should be using in the survey. And then we helped that to guide the development of actual survey questions. So you can see how that fits into this process where we initially established partnerships and got ethics approval, and then we formed the project advisory group. We did focus group discussions, and by identifying themes, we designed the survey, which we then refined and checked and then implemented. So as I said, we implemented the survey in 2023, and we had a pretty good response rate of, we had 368 surveys completed, which when we took out doubles, we had 302 people participating. We've done, because we're looking at an experience measure and we wanted to do psychometric testing of that, we have done an exploratory factor analysis, and we are going to be going through and doing the survey again next year, and we'll do a confirmatory factor analysis. And we have, of course, disseminated the findings as well, which I showed you just a moment ago, the report and the plain language statements. So just to look at the project advisory group, it's a really large project advisory group. It's got 17 people, and the majority membership is people with experiences of using drug and alcohol services and peer workers from CARMA. So 11 out of the 17 identify as having had some experience with using drug and alcohol services. The other members are from ATOD, so myself and 2 colleagues, and then we have 2 members from our drug and alcohol services, and we also have a member from the government from the drug and alcohol policy area. So together, this group meets when the project is active, it meets sort of monthly approximately and helps to guide the project. And Chris will be talking in more detail about some of the activities that we did as part of that. We also did focus group discussions, and importantly, we identified 12 groups that we wanted to talk to, and this was sort of represented different demographics and also different sort of types of services used. So, for instance, we talked to young people and older people, women, Aboriginal and Torres Strait Islander, and then we talked to people who had specific service experience with harm reduction services, with opioid maintenance treatment, with outreach programs, etc. You can see them here. And when we spoke to them, we took a really open approach. We wanted it to really be a discussion. And so we framed the discussion around two main questions and tried to really encourage people to engage with those questions. So we asked, if you think about a time when you had a good experience in a drug and alcohol service, what made it a good experience? And that really launched a whole conversation and enabled us to engage in a more kind of conversation way rather than a highly structured way. And then we asked a follow-up question later in the group discussion: if you had a lot of money, what about the service would you improve? And that also led to a lot of discussion. We also spoke to service providers and policymakers as well to sort of reflect back what some of the themes were that had been raised and ask them what they thought of those. So some of the things that service users said made a good experience at drug and alcohol services are shown here. And this is actually a picture or a diagram or infographic from the report. So if you miss it, can't read it all at the moment, go back and have a look at the report and you'll see it all there. Because I'm just going to focus on how we used some of those ideas and translated those into questions. Some of these questions are questions that the group came up with ourselves, and some of them come from other existing measures that we thought were like, oh, they were good, so let's not reinvent the wheel, we'll just take those ones. So you can see, for instance, I've just picked out like 4 here. You know, there was a theme where people talked about how important it was to access workers with lived experience of using alcohol and other drugs. And so we translated that into an item that said, I can access a worker with lived experience of AOD if I want. And you can see some of those other examples as well. So having control over treatment and support. At services, I can say no to any care or support that I don't want. Oh, and sorry, I'll just go back, but I should say that, so that QR code again leads to our publication page, but you can have a look at the actual questionnaire and you'll see that the experience measure is actually 50 items. So this is a subset of the 50 items that were part of that experience measure. So just to highlight why the SUSOSE is really important, in the ACT, it's a really key source of information that's not available from other data sources, and it's been really valuable for quality improvement and services planning in a sector-wide kind of way in particular. And also, as I've just pointed out, having an experience measure that's been informed by service user perspectives has been really important. So some of the data that comes out of it has been able to, show us about complexity of needs. So, for example, we're able to note what workers are seeing on the ground, that there's been an increase in the median age of people accessing drug and alcohol services, the extent of experiences with domestic and family violence and disability, looking at sexual identity and helping us to think about some of the needs of service users, particular needs of service users, and also looking at things like smoking and vaping prevalence as well. We were able to look at some things around service access where people identified some of the issues that they were facing. And you can see here, for example, that, the waiting times that people were reporting. So this is really the only sort of source of information that we have about something like waiting times. People also talked about self-reported outcomes, and you can see that, generally people were reporting pretty good outcomes for measures like drug and alcohol use. So that's frequency and quantity, and also risk of involvement with the police and justice system, and then various sort of health measures like quality of life, physical health, etc. We looked at satisfaction, and you can see on the CSQ8 a score of 28 out of 32. So people are pretty satisfied. So that's helpful for us to know. But we do know that satisfaction tends to rate highly. So it was important for us to look at some of these experience items. So as I said, it is 50 items, but I've pulled out 10. Is it 10? I think 10 here, and you can see from that agree, there were high rates of agree, strongly agree. So we saw from that overall people's experiences with services was pretty positive. So just to go through, the SUSOSE is then not only important as a source of information, But for us, it's actually also really important as a co-design process in itself, and involving people with lived experience as co-researchers. And this, from my perspective at least, has really strengthened the quality of the research. And so I'm going to hand over to Chris because he's going to talk a little bit more about that.
Switch places. Thanks, Anka. That's great. Yeah. Okay, no worries. Okay, so I'll just kick right on in. I will just acknowledge the traditional owners of the land on which we're meeting, the Ngunnawal people, and pay respect to elders past and present before I begin. So I wanted to speak a little bit about the value of involving people with lived experience or lived and living experience in research processes as co-researchers. And wanted to talk very broadly about four different areas that you see on the screen. So kind of early engagement and partnership development, and in particular the conceptualization of the research, and making sure you're asking the right questions. Advice on methodology and methods, and how your study is actually going to look in the real world when you actually go and do it, and planning for that in a way which gives you maximum output in terms of the depth of your research, involvement in data collection, and then data analysis, interpretation, and also dissemination through the community, and how and how it comes full circle. So you engage with the community and you get their input at the beginning, and then you use that engagement to disseminate your research back out through the community to get maximum input and maximum real world change in terms of what the research can do. So that first one, let's break it down. So conceptualization and agenda setting is a really important one. And so, researchers, obviously, one of the first things that researchers do when they look at doing a study is, what question am I going to ask? What aim is the study going to have? And so engaging with, and so that happens from a certain perspective. It happens from a research perspective, which is great. But engaging with people who have lived in living experience, or who identify with the cohort that you're interested in or working with, actually allows you to test those questions right at the beginning of your study, to make sure that they're actually meaningful to the real world, and that you can kind of have that discussion around conceptualizing, what questions are important, both from a research perspective, but also from the perspective of the kind of coalface of service delivery, or in this case, what is really important for service users of drug and alcohol services in the ACT. And then from that perspective of, okay, now we've found, what we think the real questions are that are important to everyone, then you can determine the best approach, what will work and what won't work. So that's really, and we'll talk a little bit further, a little bit later about the kind of methodology stuff that you can unpack with that step. And so that input is really important prior to ethics application, as you guys know, as researchers. Once your ethics locks in, essentially, the broad scope of your project. And so, that conceptualization will hold you in very good stead later on down the track to make sure that your ethics don't have to be changed too much, or you don't have any really critical issues or problems, and that you're not stuck in a scope which turns out later to potentially not be the best use of the research funding that's been assigned to it. Yeah, so there is obviously another aspect of this is building trust and ensuring safety. especially with people with lived and living experience or with peers. Part of the process of engaging at this early stage is building trust, that the researchers understand the community, understand the importance of the environment that they're researching within. And so that building trust is really crucial and important to the latter stages. And then also clarifying resources, priorities, and appropriate timelines. So often, if you engage with a priority population too late in your research, you may not have built in enough resources to have meaningful engagement. And obviously, it's important, just as you would cost in the involvement of professionals in your work. Well, peer workers are also professionals, and their time, costs money and costs resources. And so, and the same with service users and consumers of services, their time also costs money. And so that resourcing is important to making sure that it's appropriate, the remuneration's appropriate, and it sets you up well. Where's my mouse? There it is. Okay, so let's dig into that advice on methodology and methods, or what could we possibly, add to the complexities of finding a methodology. Well, some of the things Anka's already discussed, those groups of those different kind of subsections of the population that we're working with, people who are engaged with outreach services, people who are engaged with opioid maintenance treatment or opioid dependence treatment programming, people with, diverse sexuality, they all come with complexities and differences. And so to engage with an organization like Karma allows us to have a conversation about what are the important groups that are out there in society that we need to think about, and how do we engage with them in a way which is going to be meaningful and going to be person-centered and going to be safe for them. And one of the really interesting things about this study is that it's brought out a number of different types of safety that service users are looking for when they access a service, in terms of and not just kind of the kind of physical safety, but emotional safety in terms of their faith and their spirituality, and a whole range of different types of safety and security. So power sharing with non-peer researchers and plain language in reducing research jargon is really important, obviously. So making sure, again, that you're centering your research around that kind of nexus between the research world and dare I say, the real world. And bringing it into a realm where your research is going to be more easily recognized for a broader number of people who are viewing it, and understandable to more and more people when you try and disseminate, or when you're disseminating your research results. So getting that destigmatizing language correct, and addressing discrimination is really important. It's quite confronting for researchers and for everyone to realize that stigma and discrimination is still, unfortunately, something which we need to actively fight and recognize. And I constantly try and recognize those things within myself. And it's a really important part of reflective practice and quality improvement. And, so by having those discussions, that's a methodology stage, and building that into your latter work is really important. And then obviously some of the kind of the words which we say a lot, but which don't, which are often which often there is a lack of understanding around, in terms of being truly person-centered and being trauma-informed, again, really important. So we'll continue with methods and methodology. So what am I talking about here? I've forgotten. Just give me a second. basically coming from lived experience perspective. Sure. So there's a number of different aspects to engaging with people with experience of using drugs and ATOD services in terms of ensuring your perspective is correct, and um, and knowing how to ask questions in a way which you're actually going to get really representative responses of what the issues are that are occurring in real life. And so the addition of people in your who have experiences of using drugs and drug treatment services in your research. Make sure that you're asking the right questions in the right way, using the right language. Advice on logistics is also really important. Often, we kind of tend to think that quantitative research is very complicated, and qualitative research must be quite simple. Getting a research group together and asking some questions, but actually. Getting together different groups of individuals and asking questions in a way which is going to elicit meaningful responses is actually really tricky, to make sure that they're safe, to make sure that you're actually getting to the nub of the issues. And so by having a co-presenter or a co-researcher there who have those connections to the peers in the room, or those people with lived experience and lived and living experience in the room, really ensures that, again, you've got the right size groups, you've got the safe atmosphere, you've got referral pathways in the background to make sure that if any trauma does occur or any safety issues does occur, that you're not just giving someone a number to ring after the session is over, but you're actually able to pull the person out and to actually make sure that they're safe, and make sure that they've got support right then and there, as well as provide those referrals. So, really unpicking that trauma and making sure that safety is at that highest level. Obviously, one of the key functions that Karma plays is providing access to participants in the community. So we often get labelled as a hard-to-reach community, and I guess from our perspective, we're not hard to reach. We are everywhere throughout society. It's just that perhaps people don't know how to reach us. And so, we provide that access and that safety, and make sure that you can get the groups that you need to get those different perspectives. We've probably talked about most of this stuff. So one of the other parts that I'll just cover very quickly, we're probably running out of time already, is in terms of that co-facilitation I was talking about, it's not just about improving the safety of the groups, it's about really eliciting the right responses. A lot of the time, people who use drugs, people who use drug treatment services, we can speak a different language from researchers, and so translating back and forth between the two groups is really an important function, and it's a little bit it's very pigeonholy and very human for me to say, oh, researchers are over here and peers are over there. But the point, I guess, being that when the people in the group are talking the language of the street, for example, or when the researcher is used to using quite technical language, peer researchers can relay that and translate that back and forth. The other thing is that, of course, peer workers have their own lived and living experience of what's happening. And so, we often know when to ask what question in a way it's safe and is going to get the best response. And so, by kind of balancing carefully that dual role of being a researcher, but also having that lived and living experience, you can get the maximum out of focus groups, and really provide and get some really deep insight and really elicit some good responses from your participants. So we talked about leveraging peer organizations to make sure the environment is safe, and debriefing is also important. And this works both ways. So I worked recently with a researcher who was kind of a non-peer in that space, but because of the whole group atmosphere, there was this kind of a expectation that the researcher themselves would have to explain their history in terms of drug use. And so it does work both ways. It's a two-way street in terms of providing that maximum level of safety, making sure that the researchers are safe, as well as the participants. So again, as we go through the process, then enhancing understandings of what you've actually researched is a really good function, and breaking those discussions down and having those discussions was a big part of the process. It was okay, now that we've actually asked the questions, not only do you have to work out which questions are appropriate to ask, but then you have to work out, well, what does this all mean? And again, consumer representatives as well as peer workers, have a different and sometimes different perspective, and it can enhance understandings. We can challenge viewpoints and provide alternative explanations to data sets. And then, of course, lastly, after you've got your, in this case, our 5 brochures all done and dusted, then that feedback into community can happen. And so the pictures on the screen are of James presenting at last year's APSAD, and of Anka, Taylor, James, and Karen presenting in the park at a community barbecue when we launched SUSOSE. And so those brochures are in, for example, a Karma drop-in center, and we often have people come in and open them up and want to discuss that. And so, and one thing that came out really strongly from the study was that people who are engaged in participating in the project were really keen on getting the results back in their hand to work out, okay, so I've engaged in this process, so what are the results here? Let me understand that. And so by working in this co-designing manner, you can really enhance that and really make some positive change in the community. There are a number of principles that we used for this collaborative research partnership with people who have lived and living experience of drug use and of using drug treatment services. How much time have I got? Okay. So I think I'll just go through them really quickly. So some of the kind of principles are around meaningful involvement. So you can, and so this wasn't about just ticking a box. We had to really carefully think through what meaningful involvement looked like, remove barriers to meaningful involvement, but also make sure that we set clear expectations about what we expected from lived and living experience participants in the research. So one example, for example, is that one lesson that we learned was that having people online as well as in person at meetings wasn't really working properly, and so we needed so as we go forwards, we'll set that expectation that people need to come to the group, and we all need to be in that same room and in the moment because of the complexity of the research that we're doing. Spending the time to unpack the research again was pivotally important. So, there needs to be an acknowledgement that that research that all researchers kind of do as part of their everyday work can be quite challenging and difficult for people to wrap their heads around. And so through the process, it was really important to put extra time aside to discuss some of the really basics about how research works, why we're asking questions, why we have to keep on going back to those questions we asked, why we can't just change it up, and follow through to those results and to disseminate the results. So I'll probably leave it there, but really valuing diversity of perspectives was also really important. We had a whole range of people who who were abstinent from drug use and were on a journey that they called recovery, all the way through to people who were actively using drugs and employing harm reduction techniques, and felt like drug use is was one of their human rights. And so valuing that diversity of perspectives, it was really important in order to make sure everyone's safe, and that and actually acknowledging that safety means different things to different people was also really important. So, and then I just wanted to finish off with, of course, there is a myriad of value back to the actual consumer representatives and the peer workers involved in the research process and being involved as co-researchers. The community development opportunities are extensive. And so if you do have a community controlled organisation, there are lots of us all across Australia, then not only can you get consumer representatives involved, but then you can do wonderful things like turn consumer representatives into peer workers and really grow and allow us access to a new world of opportunities for the personal growth and the development and the livelihood of consumer participants. So we had a cohort of people, some of whom had just completed residential rehabilitation and were looking for that next opportunity. And so not only will we be able to kind of bring them along for this wonderful journey of co-researching, but we were also able to provide pathways for them to be trained in harm reduction and what peer work is. And now we have some peer workers such as James who've come out of this engagement in a really positive way that's really affirms in a positive way the lived and living experience that they've gone through in their lives. And I think for me, that's probably one of the biggest things with this research was watching the consumer representatives grow, watching them wrap their heads around peer research, learning how to present, learning how to go to a conference. And that hunger really does shine through in people when you present them with true and meaningful opportunities in a way which which respects them and treats them as equals in the power structure. And really, I think that's pretty much all. There's a summary here of everything that we've talked about. And do you want me to talk about next steps? Or?
We can leave it there, I think.
Yeah, I think we're running out of time, so we'll leave it there. But thanks very much for the opportunity to speak.
Stop sharing.
Oh, well, thanks so much. That was really such a thoughtful talk. So thank you. I really enjoyed listening to you talk through how you went about that project. It was very, I mean, it's something that we hear a lot about, isn't it? This kind of engaging consumers and working together, but it's really nice to have a real tangible example of what that looks like and what that can be like in practice when it's done really well. So thank you both for taking that time. Okay, so I'm going to do my job as chair, and I can see that James has just shimmied up to the screen. So I'm going to ask you, James, if you had any reflections or thoughts that you'd like to share with us before we get into a bit of a discussion. Over to you.
Yeah, sure. I won't take long. I'm James. I am a peer treatment support worker now at Karma. I identify as somebody that uses drugs and alcohol and other drug services for the last 30 years, all over Australia and even in other parts of the world as well. So I've got a lot of experience of what it's like to be a consumer of alcohol and drug services, and over that time, even participate in lots of different research projects and questionnaires and different things that were offered at the different places that I was at. And to be honest, over the years, I was often presented with things that I had no idea what I was answering. Some of the words and questions were sort of put in such a way that I answered A, B, or C and didn't really understand what was being asked of me or anything. And that's not an uncommon experience, I think, for a lot of people. And I have I gained a wealth of experience and knowledge over the year and was really passionate about wanting to participate and have meaningful involvement, but just wasn't quite sure where or how I could do that. There were a couple of opportunities over the years that presented, and when they did, it was really wonderful to be able to participate. As to this presented itself here in the ACT when I was at the end of a long residential service, and I was looking at what would be my next steps. I wasn't quite sure, and a pamphlet come across a desk about participating in this SUSOSE project, and I thought, oh, I'll have a go at that, and I filled out the form, and then I turned up at the first meeting. And I'm not from Canberra. I was only here because of a particular service that's offered. So I didn't really know anybody. I wasn't sure what I was going to do, and then I started participating in this project. And I think it's important to say, Chris mentioned a lot of stuff that the environment was safe, it was encouraging, there was a diversity of different people from different services throughout the ACT, of other consumers that were there, and you sort of were able to look around the room and feel safe to learn and grow and work out what this whole project was about, and then how to participate in a meaningful way. And that was really important. It allowed ample time for us to be able to really understand and engage in the project, and also give our input, which was often not asked for. You're sort of over the years fighting stigma and discrimination, and then you don't even think that your opinions and thoughts are valued or your experience is valued, and that wasn't the case in this project. And so it was good to go through the whole experience. For me personally, I got to connect with others, I got to build my own confidence, and the project led to the opportunity to do work placement at Karma, and then I got employment at I got 3 jobs at once doing in residential settings, but it stemmed from being able to participate in a project that allowed me to build my confidence. And I think there's a sort of 2 sides that I think are really important, is that as a person who uses drugs and alcohol and drug services for a long time, we have a wealth of knowledge and experience to give. But on the other side of that coin, there is a lot of we can learn and grow from the experience of participating in and build up our own confidence in heading whatever direction we decide to head. Mine happened to be into the AOD sector and the community services, but we need that space that I think it values on both sides. So one for the researchers and for projects, but also for us personally. And I mean, what better than to be able to, use our knowledge and experience. But it was a great opportunity that is, come to full-time work, but also has gained a greater understanding on, what research is about, what it's like to present the information that's gained. It's invaluable to be able to do it. But that's enough from me, so thank you.
No, that's great. Thanks. I mean, I really appreciate you sharing that, James. It's really interesting, I mean, I'm a researcher, and hearing your experience of coming into the research through a project like this, it's really great. It shows it's been done very well, and everybody, and just that you felt very included and valued, which is fantastic. So thanks for sharing those views. That's great. We've got a few questions. I've got a couple of questions. I'm actually just going to take my privileges as chair and start. One of the things I noticed from some of the data that you provided was that there was it was overwhelmingly positive, right? There was a lot of positive experiences. People were quite satisfied with their experiences coming in. Peer workers were getting a lot of positive feedback, as were the service. And I reckon that's pretty impressive, like across a range of services, to have that sort of feedback. I don't know if that would be true for other services, like I think any health service would be really chuffed to get those kind of results. So I guess my question is, were you surprised to see that sort of feedback? And what do you kind of make of that? Is that something that's expected, do you think, knowing the culture of the organizations that you're working with?
Yeah, this is interesting, Sarah, because yes, I think probably we were a little bit surprised that it was so overwhelmingly positive. I think in general, the services in the ACT do pretty well. I think, and certainly that was some of the feedback we got when we did the focus groups, that generally people's experiences in the ACT, particularly people who've experienced other like services around the country, that they do speak reasonably highly of AOD services in the ACT. And I think also that issue around stigma and feeling, yeah, issues around stigma. It's a little bit difficult to like know whether that's like a genuine response. People genuinely, generally were saying like, oh, we don't feel too stigmatized when we access drug and alcohol services. But I think there's probably a whole bunch of things that we have to be cautious about, because there's potential bias in responses where, people, all the kind of basic things that we often find with experience and satisfaction measures apply probably double fold here, where people may feel uncomfortable, responding. So I think we do have to be a little bit cautious about interpreting that as a highly positive thing. And it is something, I'll let Chris also address it in a moment, but it is something that I think we'll be thinking about when we do the next survey in 2026, about trying to potentially tweak some aspects of how we implement the survey so that we can try and reduce that response bias and really encourage people to respond in a genuine way, rather than just kind of like flick through, which we don't know, but there's definitely the potential that that's the case. Chris, I'll let you add.
Yeah, I mean, look, from one of the things that I was really excited about with this project was that we were going to hopefully be able to get people's real perspective, like how they talked at home with their friends, as opposed to what they expected that people wanted to hear. We know, or it's something that I'm deeply aware of as a person who has done it myself, that, self-stigma is kind of, it really significantly impacts the way that you engage with healthcare services, and you're really afraid, like, you're not kind of thinking, oh my goodness, this service isn't as good as it can be. You're thinking, oh my goodness, thank you for providing any service to me. And so, part of the journey for us was to try and, that was what was really important. One of the important things for me was about unpicking that experience stuff and trying to get some really positive, and not really positive, but some really truthful answers. And I think I'm not honestly, I'm not sure how successful we were. But we'll keep trying. And the sense that I get is that that's why this trust stuff is really important, for people to feel trustful enough that they can just tell the truth, and they don't have to say, yes, everything's fabulous, please don't take it away from me, or to punish me. So, we'll continue to tweak questions as we see people, as we see people's responses, to try and get that true measure of what people are feeling when we're not looking.
Yeah.
And I think it's part of that. That's why some of that dissemination and feedback is really important, because we're now able to, so that picture, that pamphlet shot that we had on one of the slides that Chris was talking to, like, that shows high positivity around experience. Like, if we're now able to show that to people and kind of go, look, this is really, really positive, but we're not really sure whether this is what the picture is. This is why it's important for you to answer truthfully in this survey, because maybe this is not the picture. So I think over time, as that trust grows, we'll, get more and more kind of truth behind the answer. Did you want to say something too, James?
Yeah, I think I sort of second what Chris said, but I think sometimes you don't even know not to be thankful. Like, it's just, this is what's given, so you just, okay, I better take it, and you don't know what you don't know. You don't know that you have the right to go, oh, hold on a minute. And quite frankly, sometimes you're just thankful to get the bare basics, that you don't want to dare risk anything more. And that's that self-stigma, and the stigma we also experience as well. Yes.
Yeah,
That was an
absolutely.
excellent question.
Yeah, well, they were excellent answers. That's really thoughtful. I mean, it's such an interesting area, isn't it? And I appreciate Libby Top has actually just popped an article in the chat as well, in the Q&A as well, talking about the experiences of stigma and how it shapes your expectations of going to health. And it's, I mean, I think that's a really interesting area, and something that, I mean, you're really kind of genuinely getting into in many different ways. So it's interesting. Okay, so the next question is from Maggie Hall, who, it's just flipped off my screen. Oh no, here it is. Who's mentioning a book that she's written, and she's saying, how can we really share the power between academic researchers who have so much power by comparison to people with lived experience, or people who are accessing services? How does that actually look like in reality? And then she's also kind of flagging, what happens if people experience a lapse or a relapse and they're involved in a project like this, and how is that managed? You know, I guess going forward, trying to manage everybody's needs and still progress the project. So any thoughts on that?
Yeah, sure. So great questions, Maggie. The first one is to engage around that conceptualization stage. That conceptualization stage is pivotally important. If you wait until after ethics is done before you engage, you're not going to get as good a research as you can get, because you won't have been able to, even if you do say, oh, we'll provide X amount of resources for this, that, or the other, you're rolling the dice as to whether or not those resources are going to be sufficient, and therefore you're rolling the dice on your research. So by starting off early and not kind of thinking, all right, well, the most important people are the research community, and then after we've kind of done the basics, then we'll open it up, by starting off with that, okay, the most important person now to engage with, so Chris is starting the project. The second person that I'm going to talk to about it is going to be people with lived and living experience, people working on the coalface, because they will, almost guaranteed, is that the questions that you think are important won't be the questions that they think are important. And by proving that they are actually the most, that it's person-centered, that's what it means to be person-centered. That's the only way you can actually do it properly. The second question was
about taking care of people
yes. So so it does happen, you know, it happens, and you can, and so but it's what you do with them. So relapse occurs, you know, if you're in that kind of paradigm where relapse occurs and you're looking for abstinence, then yes, engaging with groups where you've got mixed participants, you know, that can happen. It's what you do after that happens that really counts. And so I'll give you an example. We had a women's group. It wasn't a research group, but I think it parallels, where we had a mixed group, and one of the women just happened to start talking about how much she loved heroin. And that set off another participant to go and relapse. But luckily we built trust within that group. And so the first thing that person did was to reach back out to us and to her peer treatment support worker at Karma and say, I'm really disappointed in myself, and I don't know if this group's safe for me, and I've relapsed. And then we were able to provide a whole range of support for that individual, and ensure that that group didn't actually didn't actually negatively impact someone's health long term, and turn it into a positive thing where we provided support.
Yeah, great. That's a really beautiful story. It's all these kind of unintended consequences of getting people together and asking questions and things to be wary of. Look, we're just at time, but I am just going to sneak in one last question that is on the chat before we wrap up, and because it's a good one. So this question is asking about the survey, to my understanding, was across multiple service types.
Yep.
So how do we use that information then to, in development and improvement of the different types of services? Like, how much can we put it together and then aggregate it and use it for service improvement?
Yeah, so when we look at the data, we have put, particular services together. So we look at harm reduction services all together. We look at counselling and case management services together, and we are able, because it's relatively small numbers. So our response was 302 people because it's point in time. So there is limited utility to applying it to individual services, but on a service level, we're able to look at things like, particularly from an advocacy body's point of view, and we provide workforce development support, for instance, where we're able to understand things around the needs. There are, high domestic violence, high smoking rates, a number of those particular things. We're able to then apply apply that to what we're doing in the workforce development space and advocacy space. And similarly around experience, like if we're currently, the data is really positive, but if we got a little bit more spread, and once we start looking at factors, it'll help us a little bit more about, like, what are some of the things we have to address? How do we support workers to be more passionate and caring and whatever, things that we know that service users find important.
Oh, great answer. Okay, thanks. I'm really sorry, but we are actually at time. As always, the hour has just spun past. So I'd like to take this opportunity to really thank the three of you for coming along today and sharing your experiences and your study with us. It's been really interesting to hear about something a bit different to what we normally talk about in our webinars, but I found it really interesting, and congratulate you all for being involved in such an important piece of work.
Thanks for inviting us. Thanks so much.
No, you're always welcome. So just before we wrap, I'd just like to flag our next week's webinar, which is going to be presented by Maud Grusenstein. And this is going to be engaging in OAT in New South Wales. So we look forward to seeing you next Thursday, as always, at 3 o'clock. Thanks, everyone. Have a nice afternoon.
Thank you.